Dear colleagues, welcome again to CSC's 2020 virtual meeting. I'm T2 Rudski from the Israeli Heart Center Jewish General Hospital in Montreal, and it's a pleasure to be here. Today I'll be talking to you about the echocardiographic assessment of the right ventricle. My relevant disclosure is listed on this slide. My talk has a number of objectives, including identifying all the components of the right ventricle on standardized echocardiographic views. We'll be discussing how to correctly measure RV size and dimension and identify abnormal RV dimensions and anatomy. We'll be evaluating RV function using quantitative parameters, correlating which quantitative parameters of RV size and function have a diagnostic significance and can predict clinical outcomes in select conditions, and also review the need to integrate variables to adjust to different clinical scenarios. I like to start off by emphasizing clinically how important the RV is. Take, for example, these three patients. Who's sicker? We have patient A, who has a significantly dilated left ventricle, 65 millimeters, severe LV systolic dysfunction with ejection fraction of 20% moderate MR. Patient B has a small LV with a normal ejection fraction and no MR. Patient C has a mildly dilated left ventricle, mild to moderately reduced left ventricular ejection fraction, mild MR. And for those who know me, the answer to all questions like this is, it depends. Well, here we see the answer as always, it depends. The first patient with this severe LV dysfunction and the defibrillator wire, you can see, is short of breath because there's no stroke volume, mostly related to left-sided problem. The second patient with a small left ventricle, which is dynamic, has PAH and severe RV systolic dysfunction, so his stroke volume is similarly reduced, but this time it's related to an RV problem, so this patient is short of breath. And the third patient with the ejection fraction of 40 to 45% has severe tricuspid regurgitation. So there's decreased forward flow because everything from the right ventricle that's being pumped is going back into the right atrium and not going forward into the pulmonary circulation. So the problem with the previous scenario is they gave you no information about the right ventricle. This brings us to the first fundamental equation of cardiology, which is, in the absence of shunt, R equals L, or the stroke volume of the right ventricle is equal to the stroke volume of the left ventricle. So if the RV is not pumping to feed the pulmonary circulation, ultimately the left ventricle doesn't have blood to pump to the rest of the body, and the patient is therefore symptomatic. So let's move on to how we actually image the right ventricle. There are, as you can see, a wide variety of views that we use. We hear all about how difficult it is to evaluate the RV by two-dimensional echo due to its complex shape and its anterior position in the chest. As a result, we need these multiple views from multiple imaging planes that we mentally stitch together. Here we see the most common views that are used in our routine study. We're going to review which views are used to visualize the various walls or segments of the right ventricle. The anterior wall, as can be seen in this slide, is best seen in the two parasternal views, the RV inflow view, this is obtained by tilting the probe caudally towards the hip. This is usually thought of as a view to see the tricuspid valve, but it's also very useful to see the anterior wall of the right ventricle. The parasternal short axis also shows the anterior wall. The inferior wall can also be seen in the RV inflow view. It can be used to visualize more limited degrees of RV infarction or a more distal occlusion. The parasternal short axis view shows the inferior wall as adjacent to the infraseptum and the LV inferior wall. This view can be used to closely look at suspected RV infarction or to help distinguish between an RV infarct and a pulmonary embolism. The right ventricular outflow tract segment is seen in the parasternal long axis view and the parasternal short axis view. The myocardium of the RV outflow tract is of different embryologic origin, and RVOT function may be discordant with function of other segments. Finally, the wall that we're most familiar with, the so-called RV free wall, which is really a non-anatomic name, this provides much of the well-recognized base to apex motion that we'll cover soon. It's seen in the apical views as well as in the subcostal view. A brief word about the coronary supply to the RV. As can be seen by the various colors in the legend, the RV free wall is supplied by acute marginal branches, while the inferior wall is supplied by the PDA. The RV has a complex three-dimensional shape that is difficult to measure by two dimensions, but for simplicity and applicability, the RV size is best estimated from the apical window using the RV-focused view. This view was derived to account for the variable size of the RV chamber in the apical four-chamber view depending on probe rotation. As you can see, rotation determines where you cut through the pyramid. The RV focus view ensures the greatest dimension by cutting through the so-called apex. This table shows the reference values representing 95% confidence intervals for the different dimensions that we can measure. The most commonly used measurement, as mentioned above, was the RV basal diameter, whereas anything greater than 42 millimeters unindexed to BSA is considered abnormal. Please note that these are unindexed values to either BSA or to gender. Other measurements that we use include the parasternal long axis RVOT view, which is still one of the criteria for the diagnosis of arrhythmogenic cardiomyopathy, previously known as arrhythmogenic right ventricular cardiomyopathy. Moving on to RV systolic function, we have both regional and global measures. The regional measurements focus mostly on the base to apex motion of the RV free wall. TAPSE, or tricuspid annular plane systolic excursion, measures this motion from the onset of systole to the end of diastole. What you do is you place your M mode cursor through the tricuspid annulus and you activate the M mode, and you measure from the M mode tracing the distance excursed by the tricuspid annulus from the beginning of systole to the end of systole. TAPSE has reasonable correlation with global RV function in many cases, and is also prognostic in pulmonary arterial hypertension, among others. The lower reference limit is 17 millimeters, and it's one of the preferred measurements because of its simplicity and reproducibility. In tissue Doppler mode, we can use the S prime, or velocity of systolic exertion. Similarly, pulsed wave sample volume, pulse Doppler sample volume is placed in the tricuspid annulus, and you activate and you get a pulsed Doppler signal, and note that the S prime is the systolic velocity. In the right ventricle, you have to make sure that you don't take the first spike, which is often the isomic contraction spike. The low reference limit for the S prime is 9.5 centimeters per second, so less than 9.5 centimeters per second is considered abnormal. This measurement is somewhat angle dependent, and both the S prime and the TAPSE previously mentioned in the slide before, it should be recognized only measure regional function of the tricuspid annulus, and therefore are just an estimate of global systolic function, and a poor estimate at that. Fractional area change is somewhat more global, but it also ignores the right ventricular outflow tract and some of the other segments. It's measured by tracing the RV end diastolic area and the end systolic area. So the percent fractional change is end diastolic area minus end systolic area divided by end diastolic area. You have to be very careful to trace the compacted myocardium. In other words, you can see the dotted line is deep to the trabeculation of the right ventricle, and it really is hugging the trabeculated myocardium. The lower reference limit is 35%, and it has prognostic value, but one of the limitations relates to the reproducibility because of the challenges of the trabeculations. Finally, of the traditional parameters, the right index of myocardial performance, or RIMP, is an estimate of the ratio of ejection work to non-ejection work of the right ventricle. It can be measured from the RV inflow and outflow pulsed Doppler velocities, or by tissue Doppler of the tricuspid annulus. The advantage of the latter in panel B is that it's obtained from the same beat, so our variability is less important. In either case, it's calculated as the time from closure to opening the tricuspid valve minus the ejection time divided by the ejection time. The MPI is prognostic in a number of conditions. An upper reference limit is 0.54 when used by tissue Doppler and 0.43 when used by pulse Doppler. While considered novel, 2D strain or speckle tracking or feature tracking has been in use for well over 10 years for the right ventricle. By following ultrasound speckles throughout systole, an estimate of strain can be calculated by segment. For the RV, the free wall strain is based on averaging the 3 free wall segments, but has been shown to be quite reproducible, and provides also very good prognostic value in a number of conditions. The value of minus 20% as the low reference limit is somewhat vendor specific, and there's a lot of inter-vendor standardization that needs to be published for the right ventricle. There's more data on the left ventricle in terms of standardization, but this is still a moving target. As a result, the last iteration of the guidelines in 2015 did not recommend this as a standard value, but it certainly can and should be used in specific conditions where it's been demonstrated to show prognostic value using the recommended values for the vendor that you are using. Three-dimensional echocardiography promises to overcome the anatomic limitations of 2D echo as it applies to RV's complex geometry. While newer generation analysis software simplifies the process, there's still a significant learning curve, and the analytic packages are dependent on image quality. Published literature on AI algorithms showed limited ability for the analysis to be truly automated. It should be noted that RV volumes are smaller than those obtained by MRI, but the RV ejection fraction closely correlates to that what you get from MRI. Normal values are shown by sex and age, but in general, an RV ejection fraction of below 45% is considered abnormal. Recently, studies have demonstrated reduced survival in a variety of conditions with RVs less than 45% and particularly less than 40%. So that was all theory, but what about in real life? Here we have 3 examples. Hopefully the one at the bottom will play. So the one at the top left corner is obviously normal. The one at the top right corner is a transesophageal echo patient on ECMO on dobutamine with an akinetic right ventricle. But one in the middle, on the bottom, it's not entirely clear. There seems to be reasonable motion of the annulus, but overall just looks a little bit off. So is this mildly abnormal or is it low normal? And this is where quantitation comes into effect. So here we're looking at the quantitative parameters applied to our unknown that we just showed you. The S prime is 9.5 centimeters per second, which is the lower reference limit. TAPC is reduced at 13 millimeters. And if you look at the free wall strain, the average free wall strain is minus 20%, which is also the low reference limit. So you can see here the quantitation matches our eyeball, where it's either just on the border of low normal versus mildly reduced. So here we have a summary slide of RV systolic function, the parameters that are recommended by the American Society of Echocardiography. They are TAPC with a lower reference limit of 17 millimeters. We can see the limitations and clinical applications for each one of these. S prime or tissue Doppler tricuspid annulus, which is 9.5 centimeters per second as the lower reference limit. Fractional area change 35%. The MPI or RIMP, 3D ejection fraction 45%, and RV free wall strain with a reference limit of minus 20%, which was obtained principally from one vendor. I'd be remiss if I didn't discuss a little bit about the loading conditions of the right heart. We assess right atrial pressure using the inferior vena cava size and collapsibility. And that's a measurement of preload, but also is an indicator of RV dysfunction and is of prognostic importance. The lower left panel shows a small collapse in inferior vena cava, suggesting an RA pressure of less than 5, and in the guidelines, the number used is 3 millimeters of mercury. In the center, we have a dilated inferior vena cava, which does not collapse at all with inspiration, and this we ascribe a value of 15 millimeters of mercury. And the lower right panel shows a borderline size, borderline collapse, which is somewhere in between 5 to 10. We ascribe a value of 8 millimeters of mercury. There are a lot of caveats to this. There's some suggestion that perhaps this should be indicated to BSA with limited data in different populations. This slide is to indicate, in addition to the preload and the inferior vena cava, is to make note that the right ventricle faces the pulmonary circuit, and prognosis, for example, in pulmonary arterial hypertension is usually determined by right ventricular function. Similarly, in acute pulmonary embolism, the RV can't overcome the sudden increase in pulmonary vascular resistance and acutely fails. RV function is also important to assess when determining the need for mechanical support, whether left ventricular support is sufficient or right ventricular support is needed as well. We're all familiar with the methods to estimate systolic pulmonary pressure, most commonly using the tricuspid regurgitant gradient. We take our continuous wave Doppler of the TR jet, apply the simplified Bernoulli equation, 4 times the velocity squared. That gives us the pressure dropping to the right ventricle and the right atrium. If we add an estimated right atrial pressure based on the IVC size and collapse, we get an RV systolic pressure. And because we're looking at this in systole, in the absence of pulmonic stenosis, the RV systolic pressure is equal to the PA systolic pressure. So I want to go through a couple of cases where the quantitative parameters don't necessarily match what your eyeball is seeing, and how one must use your integrative ability to provide an overall assessment of RV systolic function. Here we have a case of pulmonary arterial hypertension. From the upper left panel, we see severely dilated right ventricle, a relatively squashed left ventricle. In the upper right panel, we see again a severely dilated RV right ventricle. The tricuspid annulus seems to be moving quite well, but we can see that the ventricle is mostly rocking as opposed to moving inwards or base to apex. In the lower left panel, we see that classic D-shaped septum with a flattening both in systole and diastole, but principally in systole. And the lower right panel is actually an apical two-chamber of the left ventricle. Because we have an apex-forming right ventricle, you can never really get a true two-chamber. And when you actually see this pattern, it usually suggests a severe RV enlargement. Looking at the quantitative parameters, here at the upper left, we see the RV is in fact severely enlarged. But when we look at the motion, whether it's measured by TAPSE or S prime, these are in fact normal values. We all know that this ventricle looked severely dysfunctional, and if we were to calculate the RV fractional area change, we can see it's severely reduced at 18%. If we were to measure strain, similarly, this would have shown a severe reduction in strain. So what this tells us in PAH, we can't rely on indices of annular motion or velocity alone to assess RV systolic function. If these are reduced, because these segments are often the last to go, that imparts a severe RV systolic dysfunction, but it doesn't pick up milder degrees. Another example of discordant values is in the post-op cardiac surgery state. If we look at the upper left panel, we can see that the base to apex motion, or the longitudinal motion of the right ventricle, is impaired. If we were to actually measure this using our TAPSE, we can see the TAPSE is significantly reduced at 12 millimeters. But if we look at our fractional area change, it's in fact at lower limits of normal. There was a nice work by Mafasenti et al. Looking at the reduced longitudinal motion, and we see that both TAPSE and S prime are significantly reduced. Fractional area change is fairly neutral. Strain is reduced, but interestingly, RV volumes and RV ejection fraction are fairly neutral. And that's because of the relationship of the septal motion. Here we can see in the upper left panel a paradoxical septal motion, and in the lower right panel you see an extreme version of this. This is a patient with virtually an akinetic right ventricle, and the entire RV stroke volume looks like it's related to that markedly paradoxical septal motion, which is acting as a bellows pushing against the blood in the right ventricle. So to summarize some key points, multiple views should be used to assess RV function. RV inflow view to look at the anterior and inferior walls, apical floor chamber to look at the free wall, and the parasternal views to measure the right ventricular outflow tract. All RV dimensions are measured in diastole. Abnormal values include RV basal dimension, the RV focused view of more than 42 millimeters, and proximal RVOT in the parasternal short axis more than 36 millimeters. There are 6 quantitative parameters to evaluate RV systolic function. These are TAPSE, S prime, fractional area change, RIMP or index or MPI on the right side, RV ejection fraction, and free wall strain. TAPSE and S prime may not reflect global RV systolic function, as they quantify principally annular motion, and abnormal TAPSE, abnormal strain, and reduced ejection fraction are associated with poor prognosis in patients with congestive heart failure, patients with pulmonary hypertension, and a variety of other conditions. When we look at a tailored approach for our interpretation, which is something that we should always consider, we have to look at what information are we looking for. Are we looking for just whether the right ventricle is normal or abnormal, in which case we have comparisons to normal values derived from statistical analysis of healthy subjects or populations. But there's still further value in characterizing these values with traditional parameters of structure and function. What about disease diagnosis? Are we trying to figure out what this patient has, a differential diagnosis? Is it an acute PE? Is it an RV infarct? Is it pre versus post-capillary pulmonary hypertension? Are we trying to prognosticate the patient? What is the RV systolic function in congestive heart failure, PAH, and other conditions? Are we using it to guide therapy? For example, RV enlargement in pulmonary embolism, in atrial septal defect, or pre-cardiac surgery, for example, in the setting of mitral regurgitation. So on this final slide, I would like you to draw your attention to the panel on the left, which is a Stradivarius violin. Notice the right side and left side are of equal importance. It creates notes of beauty and is very symmetric. The annotation on the right is the triple integral with a ring around it, which is a symbol to integrate complex three-dimensional volumes. I would like you to think about it more in terms of integrating three components when you're assessing the right ventricle. Your eyeball assessment, what does it look like? The quantitative parameters, what are you measuring? And the context in which you're assessing the patient. Is it abnormal or versus normal? Are you trying to find a specific diagnosis? And thank you again for your attention.